Hi, I'm Dr. Mitesh Patel. I'm a GP trainee based in Nottingham.
And my name's Dr. Caroline Bowler. I'm a core medical trainee working in Kingsmill.
And this video is designed for junior doctors to try and just discuss ways to try and improve the communication between primary and secondary care.
We all know how difficult it can be being a junior doctor, and hopefully with these tips we might be able to make everyone's lives a bit easier, whether you're working in a hospital or out in a GP practice.
So first of all, we're going to look at the challenges and what should be done from primary care to secondary care when patients are being referred into the hospital. So we feel that as a junior doctor working in primary care, if you're going to admit a patient, then the patient should be aware of why they're being admitted, when they're going to be admitted. A discussion needs to be taking place, ideally with the secondary care hospital team, and any relevant paperwork, which includes information which is necessary for the secondary care team, needs to be included in the referral letter.
The same also would apply for when patients are coming for outpatient appointments. They also need to be aware of exactly who they're going to see and why they're going to see them, and also have some realistic expectations about what can be achieved in that appointment to ensure that the appointment's meaningful for the patient and the secondary care doctors. In particular, when patients are coming to outpatient appointments, it's essential that their GP, if at all possible, gives very specific details of the investigations. Sometimes due to different hospital computer systems, we don't have access to the same information as their GP would. It's essential that when patients are being referred in under a 2-week wait pathway, that from my perspective their GP needs to have clearly explained to them the urgency of the referral and the suspicion of a possible underlying malignancy, because otherwise patients can be quite unclear why they're actually at the hospital, and it can be quite a shock for the patients and their families when they arrive. It's really important that secondary care communicate clearly with the patient's GP when they're being discharged from a hospital. So that would mean writing our discharge summaries, both from an inpatient stay or from A&E, in a timely manner, and making sure that all the information in it is very clear. We've also got to be very clear about patients' medications, in particular any that have been changed as an inpatient, giving clear reasons why they've been changed, or in fact why medications have been stopped, so the GP knows not to prescribe them again. It's really important that for patients of working age that we make sure that we're giving them a fit note of an appropriate length, so they don't need to represent to their GP. Clearly we can't always predict how long patients will need off work, but if you can reliably expect that a patient will need 2 weeks off work, it seems reasonable to give them a fit note of that length on discharge.
So if a patient is being seen in a secondary care outpatient clinic, then we would hope to have a letter of communication from secondary care within 10 days. And if a patient is being admitted to the ward or to A&E, then ideally we'd hope to have a discharge letter available within 24 hours.
Letters from outpatient clinics should be clear about exactly what's being discussed with the patient, and also should be clear with ongoing actions for the patient, the plan in secondary care and also in primary care. We also need to be sure that if we're starting new medications, that we provide the patient with those a prescription for those medications of a suitable duration, at least until the patient can go and see their GP to get it prescribed further.
So from primary care, when we're referring patients into secondary care, it's important to stress to them the importance of attending the clinic that they've been referred to. If unfortunately a patient does not attend the clinic appointment, and there's multiple reasons why this may be, such as miscommunication or other external factors, then a discussion should take place with the hospital consultant, looking at the referral letter to see the needs as to whether the patient needs to be seen in clinic rather than just simply discharging from that clinic.
When we see patients in outpatient clinics, it's important to be aware of the hospital policy or guidelines related to consultant referrals. In particular, if a referral needs to be made under a 2-week wait policy, it would be the responsibility of the doctor in that clinic to make the referral. The other problem which we often come across between primary and secondary care is when patients have investigations in a hospital, whose responsibility it is to follow those up. This is clearly a very difficult area due to the throughput of patients seen in hospitals. The advice that we would give would be that all investigations are clearly ordered under the responsible consultant's name to ensure that they receive the reports of those. In individual circumstances, for very important investigations, it may also be a good idea to send a specific email to your consultant to make sure that they're specifically looking out for the results of a test that you've ordered.
And I fully agree with that comment. So when patients are discharged from the hospital, it would be great for results and investigations that have been looked into. We'll have a letter sent both the patient and the GP, so they're aware of this. And this hopefully then will inform patients they don't need to see the GP specifically to obtain the results.
Hopefully, if we can all at least try and follow some of these tips, it'll make everyone's working lives a bit easier and hopefully make patient care better if we all manage to talk to each other.